I want to welcome all of you today to our IPHAM webinar series titled Explorations of Careers in Public Health. I want to remind everybody that we use a virtual live Q&A format with our presenters, and we encourage that you in the audience ask questions by using the Q&A function at the bottom or top of your Zoom screen. Please don't use the chat function to post questions because we won't be monitoring it. Today's guest is Susan Avila, and our webinar will be facilitated by Dr. Peter Orris. Dr. Orris is Chief of Occupational and Environmental Medicine at University of Illinois Health, and also a faculty member in the Department of our own Preventive Medicine at Northwestern University, Feinberg School of Medicine. Dr. Orris has taught or co-directed several courses here at Northwestern, including a popular course that brought public health leaders to the classroom to talk about their own careers. This course was the inspiration for our webinar series today. Our guest, Susan Avila, has worked in a broad spectrum of roles spanning acute care to public health nursing. She retired in 2013 from her position in the trauma nurse coordinator at John H. Stroger Hospital, where she directed the Department of Trauma Surveillance Unit and several grant-funded violence and injury prevention programs. She's a lecturer in the University of Illinois at Chicago's School of Public Health Division of Environmental and Occupational Health Sciences. In her public health career, she also was a member of Mayor Harold Washington's administration and implemented reforms in the Food Protection Program. She currently serves as co-chair of Cook County Commissioner Alma Anaya's 7th District Health Task Force, with a focus of advising and tracking issues impacting the health of those within the 7th District. She also serves on the board of Enlace Chicago, a community organization dedicated to capacity building, collaboration, and grassroots leadership in the community of Little Village. We're delighted to have you as our guest today, Susan. And without further delay, I'll turn the microphone to Peter to get us started.
Thank you, Ron, and welcome everybody. This is really exciting for me to have Susan here with us. As I've already mentioned to Susan, this is an outgrowth of a seminar series some years ago, as Ron had mentioned. Primarily, it's directed at creating a picture of public health leaders and why they made the choices they did career-wise, what motivates them and what motivated them to get into this area, and what they see as the possibilities now for young people moving into the public health area. As I mentioned some months ago to you, the students, as part of this seminar series, there are faculty as well that will be online, but the students, the graduate students here, are students that are getting either an MPH or a DRPH or a PhD in a public health related discipline, but some are getting an MPH as a final degree as well, and some are MDs with MPH and PhDs in a lab area that are going toward MPH as well to broaden their perspective in the field. So just to let you know, and when I touch on an area, feel free to move ahead on those areas that you may think would be useful to the students. So thank you for joining us. And I'll plow right in. First of all, where were you born? Where did you grow up? And why did you decide to go into nursing?
I was born in Lafayette, Indiana. I was the oldest. I'm the oldest of 10 children. We lived for a while in Texas until I got bit by a tarantula, and my family decided that and my father couldn't get a driver's license in Houston. So we moved back to Indiana and we were Catholic, and So the nuns offered my father an opportunity to educate his oldest daughter. And there was this 3-year, at that time they had 3-year nursing schools you didn't get a degree, but you 3-year nursing schools. So I was given a scholarship to go to nursing school. And I went there, finished, and then I went back and got a bachelor's degree at St. Louis University. And that actually made a difference. I was there, I'm old, so I was there during the late 60s in St. Louis with a lot of issues going on, the closing of their public hospital, which they had 2 public hospitals, and we were involved in some of those issues. And that's where I first met and talked to people about public health. And actually, it was some of the groupings at the American Public Health Association, and even reading the journal in my classes to see that public health meant access to food, it meant access to housing, it meant the various things that were happening in the South around setting up clinics. And so I felt like while I had worked a lot, I had graduated, I had worked a fair amount in hospitals and was excited about this dimension of actually taking care of people and working with people in their communities and preventing their illness. So I got an interview everyone knew about Miles Square Health Center. It was located then in the like 3 blocks from where the Black Panthers ran their breakfast. And I took a bus from St. Louis, thought, because I'm sort of country in some ways, thought I could walk from downtown Chicago to, it was only 20 blocks and a country girl could do it. And then found out that I should probably take a bus because it was much longer than I thought. And so then I got excited and it was the sort of the reputation and the publishing that was going on about how Miles Square was a nurse-led clinic and nurses were working with the community. So that's sort of what happened. So I came to Chicago and worked at Miles Square Health Center with some of the leaders that went on to really lead public health, Ira Shannon, Joyce Lashoff, various people. And Fred Hampton had just been killed 3 years prior. And it was an area that served the Henry Horner homes, which at that time, Henry Horner homes went from Western down to, I think they went all the way down to Wood Street. They're demolished now. But they held 9,000 people within those homes. So that's what go ahead.
The clinic was interesting and an outgrowth of the Press St. Luke's set up, now Rush Press St. Luke's at the time. So a hospital catering primarily to middle and upper class. And interesting for Northwestern, because at a similar time, Northwestern really founded and helped support the Erie Clinic as an individual clinic then as well. Did that contradiction play any role? Why did Rush do that? And what did you see why was the clinic exciting?
So the clinic was exciting. And actually, I think now, we sort of back to the future in some ways, because we talk about the community, community health home advocates, community health advocates. And at that time, this was what, 1970, in 1973. So what they had established at Miles Square Health Center, and if you go back and read it, it's sort of gotten lost with the U of I taking over and kind of rewriting the history. But at that time, the whole model was that there was a multidisciplinary team, and central to that team was the community that you worked with. So at Miles Square Health Center, the dedication, it was one of the first health centers to be funded through the federal government. And it had a history in that at that time, the old Mayor Daley, the original Mayor Daley, was the mayor of Chicago. And what had happened is that the Board of Health, prior to Miles Square, the Board of Health had a nurse-run clinics that mainly did vaccination. So it was a city clinic. But at the same time, they were coming up against, right in the same blocks, the Black Panthers were running their breakfast programs and their healthcare programs. And so what happened was this idea that who's going to control healthcare in this area became a major issue, and who was going to speak for healthcare. In 1969, they killed Fred Hampton right there. He lived at 2337 West Monroe. So it was a few blocks from where the health center actually was established. So the idea was that there would be this community health center, and kind of the relationships between the community and the health center was one issue. The relationships between the community health center and Rush, which still had segregated wards. So it wasn't, so if I as a nurse from Miles Square Health Center went to go see my patient, I knew that I would be in an area of the hospital that was considered the old part of the hospital, and you would only have African-American Black patients in that area. So there was that contradiction, which people were very aware of, is that, you know, there was this, this segregated hospital that at the same time was running Miles Square Health Center. And in Miles Square Health Center, for example, almost 80% of the jobs were not given, but the commitment was to the community. It served an area that was a mile square. That's how it got its name. And I was a nurse that worked with a team of community health aides that were from the projects or from that neighborhood. They had to be. They had additional training. The demand, as it is today, that those community health aides would have education that would give them degrees. I mean, so that they weren't just sort of trained internally and then had no way to move up out of that position. So I was hired, and just sort of the first day I came to work, the team that I was with, there were 4 community health aides that worked there. They locked the door to the office as a protest that they had hired not an African-American nurse, which was good. I mean, so people were there demanding their rights continuously. So we negotiated, we worked together, and the model was that you worked with them everywhere you worked. You worked in the clinic, you worked in the hospital. It was always this multidisciplinary team with an understanding that each person bought it, and that the 9,000 people that you saw that lived in the Henry Horner projects, which if you think about it, it was almost like in Kenilworth. I mean, right now you have like 2,700 people, but there within that mile square, you had 9,000 people living in just one section of that neighborhood. And that our responsibility was to see every newborn and pregnant woman. We were given parts of that project and of the neighborhood. And also to advocate at Rush, which was a big, big issue. And to make sure and that demand that Rush include both the health aides and us in the planning for our patients when they went there. And that was always an issue. I can remember vividly being with a patient who was pregnant, who had a fetal demise, and the nurse and the doctor at Rush asking me, one, after they gave this horrible news to the patient, asking me why I didn't make sure she got a bath before she came there. That was their way of coordinating care. It was, and in the end, what happened while I was there, members of the community went actually into Joyce Lashoff, who was the person at Rush that was coordinating, and went in and demanded that they release the clinic to the control of the community. They actually so it was a constant struggle, and there was a constant fight between sort of what was happening within the healthcare system and what was happening in the demands of the community.
Would you say this was a forerunner of the current FQHC clinics today? And what were the similarities and differences? How have things progressed?
Well, so the issue is that what Miles Square was started sort of healthcare for all. I mean, it was part of that. What was the commitment is that everyone that came into that health center, even though it was Rush that was handling it, would have access to care without consideration to payment, and that they were to be cared for, and that Rush took the responsibility to assure admission into the hospital so that anybody, so in some ways, and that and I think what we've seen is a step back from that actually with the FQHCs. We did have an advisory board, but the idea and what has been cut was the idea that you had this very strong multidisciplinary team that was structurally supported, that was part of the funding, part of the way that the health center was evaluated federally, and that in fact it needed to prove that you did have the coordination between the community, the hospital, and the health center. So even when they came in to see patients, there was this idea that if I was seeing them in their homes, that I would be, walk down the hall and talk to me about it. Or if the community health aide was seeing, they carried patient loads. So they were actually structurally incorporated in the care of the patients. It wasn't sort of looking for funding for them. Now it lost funding, they changed, and now you have them, what you have now at U of I, which is somewhat, still somewhat dedicated, but doesn't have the structure that assures that community health aides exist.
And how long were you at Miles Square, and why did you leave, and where did you go next?
So what happened with Miles Square was that people went into, there was a group of community people that went into Joyce Lashoff's office and sat in her office and demanded that Rush turn it over.
So she was a physician at Rush?
I'm sorry?
Joyce Lashoff was a physician at Rush?
She was the I don't know what the position, but basically Miles Square was under Rush. She was the person that represented Rush, or was the structure that represented. We had a director of Miles Square, but then that director answered to Joyce Lashoff. So there was a big fight in the community for very good reasons. And so then what happened then, though, is that there was also, when they broke the connection, some of the benefits that were employee benefits, and they began to fire people. There were back and forth. So people started joining a union, and I worked with them around a union for the people at Miles Square Health Center. And that, and as a result of that, was transferred out of the hospital, out of the health center. And at the same time, they did get rid of what they called they called us the field nurses, that we went out in the field. We went out into the community with the team, the field team, they called us. And so they got rid of that, they cut that, and they put me as a discharge planner at Rush. So, and then it was clear that I was going to be fired. And so then I took a position at Rush. I transferred and was a nurse at Rush, and then I worked some inpatient and the ED, and then I went to work with them in their, as their, they established their own home health, and I worked there for a while. I worked at UC. I worked at various other hospitals for a while and inpatient. And then while I was at the University of Chicago, I got a call actually, after Harold Washington. I was working labor and delivery at the University of Chicago. And then I went to, I got a call from people working in the new administration of Harold Washington asking, did I want to come and supervise the food inspection people for the city of Chicago? And I told them, I don't know anything about food inspection. I'm a nurse with public health, but I don't know anything. And they said, well, you know more than the precinct captain that is in charge currently of the food inspectors. They had been, under the time of Daley, they had been moved from the health department over to the Department of Consumer Affairs because they were taking bribes. And they actually had an elaborate scheme of bribe taking. And so there had been an investigation, and I mean, this is just the story that was told me, that someone came to investigate what was going on with the food inspectors and the bribes, and that person then was found dead in their hotel room. So I don't know if that's true or not, but the investigation never happened, and then they were moved out of the health department. So after the election of Harold Washington, the idea is that they were going to be moved back to the health department, and that I would help do that transition. So I interviewed and ended up going there and working there for almost 2 years. That was an experience. And I remember because they all had been, some of them had been fired and convicted. They had an elaborate scheme that even involved judges. So you had a food inspector that would go inspect a restaurant, and then what would happen is there would be violations or whatever. So then they would take the bribes that would happen, and then there was a whole system where that bribe money, sort of checks and balances that happened, that bribe money went all the way to the judge. So, and it was sort of timed well because they had to time it so that it got there before the judge heard the case of the violation, so that they could say, oh no, you don't have a violation. So several people had been fired, some people went to jail. So at that time I worked with the precinct captain, the major precinct captain of Michael Madigan, who was in charge of the food inspectors, who ended up getting a degree from Chicago State University in an area that Chicago State did not have. So, and that was interesting. That really, it showed to me, because you were out inspecting, they weren't even given pens. So we did move them over to the health department. And we ended up getting pens for them so that they could inspect, and began training. And what you saw was at a personal level, the real impact of patronage on these guys. It was all men, and they had never been asked to do their job other than collect the money. So it was really hard for them in that transition where you did education and talked to them, and they had never even interviewed for a job. They didn't even know how to do interviews. You had to, because they never had to do them. And it was so ingrained that when, at that time, the president was President Reagan, and he was coming to Chicago for a visit. And what happened at that time, and still happens, is that he was going to the Palmer House for some event that involved food. And so we were called by the Secret Service to go do an inspection of the Palmer House kitchen to make sure that, it was clean and up to standards. And that, you didn't put President Reagan's life in danger through bad food. So I got the call, and I then said to the inspectors, we need to get ready. Their boss, Michael Madigan's precinct captain, was off that day. So I went to the guys and I said, we got to get, let's get your pens and your papers and stuff together, because we're going out to do an inspection and I'll be going with you. And all of them sat there and looked at me. And I said, you know, you guys need to come on. And they said, we don't do that. I said, what do you mean you don't do that? And they said, we don't do work for Republicans. So it was this whole so I found myself in a position of saying he's the president of the United States. I mean, I didn't have fond feelings for Reagan, but they were so clear that they weren't going to do the inspection. And I had to call Michael Madigan's precinct captain up and say, look, you're going to have to, someone's going to have to give, because, and he had to do the inspection himself because these guys refused. So that was a learning experience, to learn kind of moving out of sort of the Chicago patronage system and whatever, to moving into understanding that they had a public responsibility. I mean, you know, to inspect and assure the public safety. It was a transformative time. We brought women in to work. You know, it had been all white men. A lot of them were retired and doing this as a second job. Many had been police officers and retired, and this was their second, you know, supplemented their income.
So on terms of your career, it seems that you were immersed in one of the first community health centers in the country, and there were only, I don't know, 4 or 5 at the time. And this one created by HHS, Dr. Richmond, who had come out of Rush and being run by Lashoff and conceptually put together there. And so really if you will, a progressive view of community-based healthcare, which became more generalized, and as you said, with problems as it became institutionalized and generalized under the government. But you went from that public health, strongly community-oriented healthcare back into hospital-based nursing, and then boomeranged out of there almost by chance to take on be one of Harold Washington's troops, to take on the machine in Chicago, not exactly an insignificant role. Why was that back and forth? Why did you go back into hospital nursing? Were there frustrations within the public health arena or the community-based arena, or whatever? Or was it all related to the union organizing and issues internally?
Actually, because of that union organizing, I did have trouble going back into direct patient care. In fact, I didn't realize it 2 years later that when I applied for a position in the hospital, initially I wasn't accepted. And I thought, you know, I hadn't been in, you know, on doing direct patient care in a hospital setting. Later, I found out it wasn't that. It was that they had said, oh, she's a union person, don't hire her, which was sort of interesting because who would care? I mean, anyway, but at Rush was very, and U of I were very, at that time, were not unionized. Well, Rush still isn't, U of I was not. So it was an issue. I think the issue was for me that Miles Square, that time of working as a nurse was so expansive. You had so much ability to really affect what was happening. And you had a team that you were working with. I mean, so some of the people that you worked with were just really, I mean, Dr. Klinger, who just recently died, who had been in the South, who worked in the South with, I forgot the person's name that was Peter, you know, who helped set up some of those first clinics in Mississippi. He had worked with him. So he came to Geiger, right, Jack Geiger. And so he came to work at Miles Square with us, and other doctors that were there, other nurse practitioners. They were, I mean, at that time, you just had the beginning of like a nurse practitioners and it was this structural issue that you worked as a team, that each time you went, you had a community health aide that was an employee of there that was paid. And then, so you had a real ability, like when they were establishing in Henry Horner in those projects, the community residents had fought against putting mesh up. So if you went into the projects, I don't know everybody who's been in, but if you went in the projects, they were almost like prison. I mean, the way they were, because a lot of them had this mesh. So even if you went out onto the tiers and, you know, which was your outside of your door, you, in a lot of the other projects, you had these metal mesh guards up that made you feel like you were sort of just like you were in prison. And so the residents of Henry Horner had fought against that. And that, I mean, clearly there were all kinds of problems. Mayor Daley built them with, you know, total disregard for any kind of standards. But people really fought against having these meshes put out, these mesh screens put outside on the balconies. And they lost that fight. And when they began to do that, they left their materials there, and a piece of mesh, a real heavy piece of mesh, fell from one of the top floors and killed like 3 little children playing in the projects. And so immediately there was this response from the health center to go there. We were all called. It was an emergency. You went out there with mental health. There had been training in mental health that people, like sort of emergency mental health supportive. And you went there. You also went there because the police came, and for the people that were hurt, they were going to put them in a paddy wagon. So you went there to fight to make sure that they sent the ambulances, you know, and just to throw somebody in a paddy wagon. So I think that ability to do that and working with a team and understanding the relationship between healthcare and the provision of healthcare and the health of a community was so important. And that all was pretty much lost. I mean, what you saw was cutting of the federal monies, the move back from this kind of concept and into more sort of, you know, within the confines of FQHCs, which are good, but which still did not have the breadth of what. And I really didn't want to be in a clinic, you know, checking people in every day. So I went back to the hospital where I felt like at least I could do, you know, to do that. So I think that was sort of a disappointment. And then going back and working at the city was really an opportunity to feel like you could affect public health on a wider role. Unfortunately, Mayor Washington died and we were fired, but that was, I mean, we resigned because of the changes that happened. But that was an important, I thought that was an important, and if we could have kept on doing that, that would have been fun.
When did you get your master's in public health? When did you get your public
Actually,
health?
didn't go back for my master's. I went back. I could have had it if I stayed at the city and became a precinct captain for Michael Madigan, because he gave you masters, which was pretty powerful. But I didn't do that. I went back when what happened is after I left the city, then I took a job at the county, at Cook County, and initially was hired in as a nurse clinician, working in what, Peter, you know, with a team that was working in the general medicine clinic. And we used to call it the General Motors Clinic because it was run by a microphone. And it was like first come, first serve, which was horrible. But anyway, there was a new primary care grant that was gotten by a team of people, some of who I knew from when I was at the city, and I was the nurse with that team. So I went to county then. And at that time, then I went back to school at U of I and got that. So I think it was like, I went to county in 1983. No, 1988. So that's when I got it. I went back.
And this is not the typical career course for a nurse from rural Indiana and working in some of the rougher neighborhoods in Chicago, doing community-based healthcare, and then taking on the some of the rougher aspects of the Democratic machine in Chicago at an era that the struggle there was quite sharp, if we say. So where did you find this courageous streak? Did you consider yourself terribly courageous in this setting? And if not, why not? And for students today that are coming out and looking at where the most need is, but often in neighborhoods that are viewed as quite rough, if you will. What would you say to people about that in providing healthcare or public healthcare?
I think an example that kind of illustrates that is that I was in a meeting. I went to a meeting at night in Little Village, which some people might see as, in Little Village. It was in nighttime. I went in that meeting with a social worker who we had been working with from Lurie, and with a guy who actually works at county as an interpreter, but is a resident of Little Village. And he was with us. So the three of us were meeting with an alderman and some other people around some issues around a program that we wanted to start in Little Village around injury prevention. So the meeting went on, and we finished the meeting probably like at 9 o'clock at night. And so we were leaving where we, in the sort of in the house that we were meeting, and going to our cars. So at the time when we were going to the cars, a group of young men came up and started harassing us. And so the guy that was with us, that was from Little Village, said, well, I need to protect you. And we said, no, you are more in danger. And in fact, he had more of a kind of danger than we had, walking around the neighborhood. I mean, so in some ways, the idea that you're going into the danger is there from the police. I mean, from the people that live in that community have more of a chance for danger than we do. I mean, and in the essence of what you're doing, you're, going in, and clearly, we would go in when we would do the visits in the projects. So, and I both at Miles Square, and then when I worked for a while at Rush in their home health, we did visits in quote unquote neighborhoods that were dangerous. But the problems I had were in homes that were not considered dangerous. I mean, so for example, I was covering, when I was working one time as a Rush home health nurse, I was working the weekend and had to go to the building that's right on the lake by Navy Pier, up to the top floor to go visit somebody who had some cardiac surgery, that whatever, and he had a huge gaping wound. And it was a Saturday, and I at that time did not have air conditioning in my car. It was in the summer, it was hot, and I get there, and his house is totally air conditioned. It's totally nice. I do whatever I had to do, change the dressing and do whatever. He had some IV. I did all that. And as I'm leaving, he's saying, if you stay and help me, whatever he wanted, I'll give you $100. And my girlfriend left me. I mean, so I'm standing there, he's blocking the door with his IV and his wound, believing that he has the power to push me into whatever he wants for $100. So it was like, those were the situation. I mean, or the other situation when I was visiting Bridgeport, which was, considered quote unquote safe, and we were in the middle of visiting with a family whose daughter was, going on to nursing school, and we're, taking a history from whatever. The woman was sick, the wife was sick, her husband was there, the wife was in a wheelchair, the daughter was there, and I'm doing an interview assessment, and all of a sudden the patient answers some question that the husband decides isn't the right question. He stands up and starts screaming, opens up the basement door, takes her wheelchair and says, I'm going to push you down I'm going to throw you in the basement if you do this again. And I'm sitting there, so, I mean, those kind of situations are across the board. So it isn't like you can assess where you're going to get into. I mean, I think we have to think about safety, and I'm not saying that people shouldn't be safe, but sort of to compartmentalize it by neighborhood really does not serve you, and really doesn't serve the community that you're talking about.
I'm afraid I may be squelching questions. If just to reiterate what Ron had said earlier, the Q&A click there is a place that you can put in questions about to Susan, and I will transfer them out. But otherwise, I'm again totally fascinated, so I'll continue to move ahead with my questions. So you were at the county, and you were doing the primary care activities from within the outpatient clinics there, and getting the master's degree in public health at the School of Public Health U of I. And then you transitioned to the trauma unit. Now, was that right away, or were there other stops along the way? And if so, why did you move to trauma, and what was the concept there?
So I finished my bachelor's. I think I worked in general medicine clinic for like 4 or 5 years. I mean, like 5 years. I was the nurse. Part of that grant changed. And so there were changes in how things were done. And so I went back and got my master's, and also then became a diabetic educator. Myself and some of the other nurses that worked in that grant went back, and we started doing a diabetic education. And so we did that. I did it at Little Village at Jorge Prieto, and we did it in the General Motors Clinic in the GMC. We did some of that. That was early on. And then what happened is I finished my school, and then there was a position opened up in the trauma unit. It would be a promotion, and it required you to work. The state mandated that you basically would work with the prevention part. It was one of the few areas, even though trauma is run by surgeons, and I think probably, at Northwestern, they have a long history of the trauma unit there. University of Chicago County, was the first trauma unit. This idea that it isn't, even though you have surgeons there, and it clearly is a highly skilled, highly, clinical area, this idea of prevention is structurally part of how a trauma unit is certified and works, that they have to provide a section, work around prevention. And actually, your trauma surgeons often are your leading public health people, often are the leading nationally, have been the major public health people throughout the country, especially around injury. And even like after Katrina, they pulled one of the famous trauma surgeons from Texas to set up the Astrodome as they were moving people into Katrina. And he understood, he said, this is a public health, we need internal medicine. So, I mean, they're really able to understand population health and understand what they do and what other disciplines do, which I think is really important. So again, the chance to work in public health, even though I'd be clinically based or based in a hospital, was exciting. Also to move to looking at the data. One thing, they're required to collect data and report to the city, to the state. That's part of being certified as a trauma unit. And again, kind of working with a team was exciting. So I did that. I transferred over and got the opportunity to work with people like Dr. Barrett, who has left the trauma, was really instrumental in nationally and internationally around the issues of trauma and injury prevention as a trauma surgeon. So that was a good opportunity.
And this morphed into newer concepts that you and your team really, out of the trauma unit at county and in other trauma units around the country, placed upon the question of violence and treating violence and gun violence as a public health issue. Did you want to say a little more about that? How that developed?
I think one thing that was really, that we did do, and that it wasn't just, it was nationally. Clearly APHA, the injury section of APHA, many of those leaders went on to take national positions in CDC. The push, again, nationally from the trauma organizations, the physician-led, surgeon-led organizations that really pushed around this issue of violence and injury as a public health issue. I think for Chicago, it became an issue after the killing of the shooting of a famous basketball star. And he was, I think, from Simeon. He was coming home and was shot. And at that time, there was no, the fire department responded and they took you to the nearest hospital. There was no coordination. There was no system of pre-hospital, as we called it, or of coordination from pre-hospital to hospital. So this young basketball player was taken to a hospital that was not able to take care of him, and he languished there and then ended up being transferred but died. And so that whole incident sparked for the city a whole examination of their response for the ambulance services and the idea of setting up traumas. So that whole idea had been going on throughout this country, looking at coordination of care and triaging and moving care, this idea that trauma was a multi-system disease and needed to be taken care of. So that was something, they actually had an impact on medical care, clinical care of patients with trauma, is seeing it as a public health issue and making sure that all the systems responsible for that care, pre-hospital and hospital, were done in a way and were monitored by the state. So that really was under the leadership of many trauma nurses and trauma physicians. And so then within the county, what we did look at was other systems that worked. For example, at Christ, they have a trauma center. And many of the surgeons that have been trained at county went on to lead those trauma centers in the city. One thing that they had, and which we found important, was this idea of pastoral care, of services, additional services that would be available directly to people in trauma that had been injured badly through gunshot wounds, motor vehicle crashes, whatever, to support them and provide, prevent, and then to follow them as they were discharged. Also, this idea that our healthcare system does not respond to African-American men, does not respond to men, period, young men, but certainly men of color. And it became apparent to us, for example, in our trauma clinic at County, where, I mean, County is like, you know, we take care of everybody. And so, but the clinic, our trauma clinic, automatically at the county had a policeman assigned to it, which was like sort of stupid, because there was never, I mean, like, why did we have a policeman assigned to our clinic? And then when we began, this is in the early days, when we began to say, okay, so we're seeing these men and we want to transfer them to primary care, which they needed because many of them had multiple system, you know, they had a fracture, they had this, they had that, they needed coordinated care. Family practice and other disciplines were not willing to take them. They were used to having in these other clinics either older people or majority women and children. And this idea of having a patient that's a young man of color, 23, 25, was sort of unnerving and unsettling to them. So through that, we worked with others to look at establishing, and Sydney Thomas, the social worker that worked with us, and actually then one of the first people, is this Project Brotherhood, looking at an idea of setting up a clinic, which was at Woodlawn Health Center, one of the clinics that belonged to, was in the county system, where Marcus Murray and Sydney Thomas and even Eric Whitaker. Eric Whitaker had the idea and worked hard with it with Marcus Murray and Sydney Thomas to help set up this clinic that would serve African-American men. So that was one important thing. There's been other examples of that in Philadelphia and in other cities, where this idea that the healthcare system clinically or individual care for men who are mainly people that you see in a trauma center, that we're not able to really provide care beyond sort of the acute care, and that we really need to begin to think about how we do that. I think that's evolved more, and we're having more discussion around that. The other issue is the gun violence and the issue of how we begin to deal with that, how we begin to talk about that, and the role of working with, you know, Hopkins and other areas, other people that have really pushed this issue legislatively, that you need to change what you're doing, and regulations. So I think that has been led through the Public Health Association, through Hopkins, and with these very kind of highly trained clinical nurses and physicians in trauma.
So I have another question from one of the participants, specifically your advice to people graduating now on a balance between clinical activities, clinical nursing in your situation, and public health activities. Are you able to do both? Do they both help and support you, or do you find, from your experience, that you really ought to be committed to one or the other as you move ahead on your career?
I mean, the issue is like, if you're in training, I mean, clearly nurse physicians, you're trained to do clinical work. I mean, so there's a clinical skill set that you need. I mean, and you need to do that. And I think having an understanding and appreciation of that, of the clinical setting is really important in public health. I think you can do both. I think that people transition from one role to the other. And I think for me, it was important to have that clinical background, because you're still working with people, you're working within a healthcare system, and it's to have an understanding of what that healthcare system is. And I think you get that. I think there's problems. I mean, if you work clinically, for nurses, I mean, you're working in situations, you know, where you're doing shift work and where at some point, you know, let the fight for unionization in nursing is important. And people get frustrated in clinical settings. And I think like now in with COVID and this real need and understanding of public health and the need to provide services outside of a hospital setting is really important. And I think having that combination of clinical understanding and then moving it into a public health setting is really important. You know, setting up some of these vaccination sites, understanding kind of what you need, the combination of understanding how to reach out to people, how to organize it, sort of the clinical components of it, and also then the public health components. How do you begin to work with the community? How do you work with others? And that sort of goes back to Miles Square. I mean, we were providing clinical care. I mean, we went to people's homes. We did do see people in various kind of situations. It wasn't the intensity of a hospital, but it clearly was there. But at the same time, you needed to work as a team and understand that and provide that link between the hospital and the community to be able to do what you needed to do. So I think it's important to have the clinical skills. I think your education is focused on that. You want to gain that skill, and I think and it is possible to do both.
So in closing, let me ask you my Casablanca Hans Conried to Humphrey Bogart question. And that is, looking back on this career, somehow we always discover you working in poor communities, communities of color, African-American, Latinx, Latino communities, and others. What would you say to recent graduates about where to get the most satisfaction out of a career in public health and nursing? As a closing statement on my most favorite topic, race in America.
So, I mean, so in healthcare, I mean, you come up right up against that. I mean, you know, people may not say, as they said to me in 1978, you know, why didn't you tell her to take a bath? But the structural issues are there. And I think no matter where you work, in whatever community you work in, whatever setting, you know, those issues are there. And it's important to have a clear understanding of, and working with your fellow workers, with your fellow nurses, with your fellow, I mean, if you're in a union, if you have a nursing group, I mean, those are real important. I mean, that's where you can have the impact and begin to talk about racism and its structural issues that you see every day in your work. And I don't think it matters where I mean, you would see it if I went to Bridgeport, I mean, wherever you work, you come up against those issues. And I think it's important to organize and fight against them, call them for what they are, and begin to have an impact on how you work and what you do.
And we thank you so much, Susan.
Thank you so much. Good luck.
All of my expectations and hopes.
Thank you.
Really appreciate your coming
to
join us today.
Thank you. Thank you very much.
A word or two?
Nope, thank you very much.
Okay.
Much appreciated.
Okay,
Everybody have a wonderful day.
Thank you. You too.
Thank you all.